Good afternoon and welcome to today's caregiver webinar, Nonpharmacological Approaches for Managing Dementia Behaviors. My name is Allegra Jaffe and I am a caregiver specialist with the Fairfax Area Agency on Aging. Before I introduce today's speakers, I will go over a few housekeeping items. We will allocate a few minutes at the end of the presentation for you to submit your questions into the Q&A box in the panel, the question and answer box. We have enabled closed captionings on your Zoom panel. So if you would like to utilize captions today, please enable those on your Zoom. Today's presentation is being recorded and the recording will be sent with the slides by early next week to all the registrants. There will be also a brief survey as you sign out, so please help us by giving us your feedback. Now, it's my pleasure to introduce today's speaker, Dr. Natalie Regier. She is a licensed clinical psychologist with specialty training in working with older adults. Dr. Regier received her PhD in clinical psychology from the University of Alabama's geropsychology program, followed by a clinical internship at the Milwaukee, Virginia Clinical Gero Neuro Fellowship at the VA Boston Harvard Boston University Consortium and Research Fellowship at the Johns Hopkins Center for Innovative Care and Aging. Dr. Regier is currently an assistant professor at the Johns Hopkins School of Nursing, where she conducts dementia-related research and teaches psychiatric mental health nurse practitioner students. In addition, she is a principal faculty at the Johns Hopkins Center for Innovative Care and Aging. Her research primarily focuses on developing interventions for people living with dementia to manage behavioral symptoms, enhance their well-being and quality of life, increase their ability to remain in their homes or communities, and improve their relationships with care partners. Dr. Natalie Regier is going to share her expertise with us today. Thank you, Dr. Regier, and welcome.
Thank you very much for that introduction. I hope everyone can hear me okay. Allegra is very kindly going to go through my slides for me. So if you hear me say next slide, I'm just getting her assistance on that end. Okay. Okay, so you can go ahead and go to the next slide. All right, so I always like to start by talking about a few facts and figures, and I know that given who this presentation is for, a lot of this is not any surprise to you or not necessarily new information, but I do like to start with it because it just really brings home the point about the public health crisis that is dementia and how many people are dealing with this diagnosis. I often call it a family diagnosis because it affects kind of everybody in a family unit. And also just to remind anyone who's currently living this situation that you're very much not alone. There are approximately 50 million people worldwide who have dementia, and this number is expected to triple by 2050. And just to backtrack, dementia is just an umbrella term for a different range of conditions caused by neurodegeneration. And these include Alzheimer's disease, vascular dementia, frontotemporal dementia, Lewy body dementia, and others. And so, of course, there's a staggering economic cost associated with the management of this disease, and it costs about $1 trillion per year, which may double by as soon as 2030. There is a high failure rate of drug development efforts and concerns regarding adverse side effects and mortality risks. And most persons living with dementia do live in the community. There's been a real movement over the past 15 or 20 years to help people age in place. And that's associated with and kind of driving a lot of the work that I do related to dementia behaviors, because as I'll mention on the next slide, those are really challenging for care partners. Okay, next slide. All right, so what are dementia behaviors? These are behavioral symptoms and changes that are common to all types of dementia. So we often describe this as being nearly universal. They affect more than 90% of people living with dementia, regardless of the etiology, whether they have dementia due to Alzheimer's disease, mixed dementia, vascular dementia, and so on. Odds are that behavioral changes are going to occur. Examples of dementia behaviors include, but of course, they are not limited to, agitation, aggression, rejection of care. So that would be rejection of assistance, for daily cares like showering, bathing, eating, changing, things like that. Restlessness, anxiety, depression, shadowing behavior where someone is following the care partner very closely, or the nurse wherever they're residing, and many more. And as I said, they affect a very high proportion of people living with dementia. There's a lot of overlap and co-occurrence of symptoms. So you're probably not going to see someone living with dementia who has just one challenging behavior that they're dealing with. Oftentimes there's multiple together. There are very common clusters of behaviors that happen too. And so there's a lot of multiple challenging behaviors that people with dementia and their care partners are dealing with at one time. And behavioral symptoms can be expressed in different ways and for different reasons, depending on things such as issues with their care partner. That could be a kind of a communication issue with them, a relationship challenge that they have. There could also be medical problems that are underlying behaviors, and then issues in their environment. And we're going to discuss a lot of these later on. Okay, so next slide. All right, so why do these behavioral symptoms occur? And I won't kind of delve into, extensive science behind it, but just to sum it up, things like neurodegeneration. Obviously, there are a lot of brain changes going on with the dementia progression, deterioration in neurocircuitry, that's leading to some behaviors that occur. Also, when people have dementia, they often, as it progresses, have a lower threshold for stress and triggers. Kind of the long-winded name for this would be the progressively lowered stress threshold that people have. And so something in their environment or something that they're exposed to might have previously been just completely benign, or wouldn't trouble them. But when they have dementia, they have kind of less, a lower threshold for dealing with that or for encountering a stimuli, and it could lead to a problematic behavior. And of course, there are also changes in the ability to communicate needs. We know with any type of dementia, there's a lot of language changes, word finding difficulties. You see a lot of aphasia symptoms. And so when someone can't, as you can imagine, when someone has difficulty telling another person what they want or need, the frustrations that accompany that could often lead to just different behaviors as they're trying to express what it is they want without being able to directly say it. So that's often something that's underlying behavioral symptoms. Next slide, please. Okay, and there's a significant impact of dementia behaviors. So there's an impact on care partners. So of course, it leads to increased caregiver burden and stress, and increased cost of care, which is not surprising. There's an estimate, this is not the most recent, but it hasn't changed greatly, that it costs approximately $56,000 a year, just kind of a yearly care for an older adult when they have a dementia diagnosis than when they do not. And approximately 1/3 of the cost of care can be attributed to dementia behaviors when someone has a dementia diagnosis. Oftentimes, the difficulty and the sense of being overwhelmed with managing these behaviors at home can lead to a nursing home placement of a care recipient due to difficulty with these symptoms. And NPS stands for neuropsychiatric symptoms, which is another way of saying dementia behaviors or behavioral symptoms. There's also, of course, an impact on the person living with dementia. So they might have impaired independence with self-care activities, poor quality of life, an earlier transition to long-term care than they would otherwise have had, if at all, faster disease progression, and increased mortality. And this is all from the literature associated with the impact of these behaviors. So next slide, please. All right, there are a lot of problems with the standard care for managing dementia behaviors. For one thing, there's really no effective disease modifying medications available. And I say this knowing that aducanumab was approved, which would be the first technically disease modifying agent out there. I say this because it was approved with the accelerated mechanism without the usual FDA kind of evidentiary burden. And the two major studies done by Biogen related to aducanumab, one did not find any significance, one had some positive trends, but there were no statistically significant studies associated with that drug. So at this time, there's no statistically significantly effective disease-modifying medications available. Antipsychotics are associated with adverse side effects and a risk of mortality. Medications address a limited range of behaviors, so they might not be targeting the behavior that is most challenging for a care partner to deal with or to manage at home. And research has found little to no improvements in daily function for a person with dementia from pharmacotherapy, limited benefits to family care partners. Patients who were on medications often still manifest behaviors that occur frequently. And so these medications are not targeting the very thing that has been found over and over again in the literature as the most difficult for care partners to deal with on this journey, which would be the dementia behaviors, and don't necessarily address the most pressing concerns of family and staff, depending on where the person lives. Okay, so next slide, please. So that being said, there's certainly a case to make for non-pharmacological interventions, and a lot of the kind of top, most respected professional societies have made that case, that non-pharmacological approaches, non-pharmacological being not medication, should be the first line treatment for behavioral symptoms. And I listed below some of the organizations that have endorsed this: the APA, American Geriatric Society, Alzheimer's Association, AAGP. So that's kind of the general consensus in the professional community. Non-pharmacological interventions can target unmet needs, which could be an underlying cause of dementia behaviors as well. And so they could target, for example, and I will discuss this further later on, but for example, if a behavior is happening because someone can't communicate that they're really bored, if someone can't communicate that they're cold, that they're hungry, that they're lonely and want to socialize with somebody. And so non-pharmacological interventions address things like that, the real needs of the person living with dementia, in a way that medication does not and cannot. And also these interventions address dementia as a family health problem. They're really intended to kind of improve the well-being and quality of life of the whole family unit. They can often re-enable people to function in their home environment, rather than, having to transition earlier than they would to long-term care, or even prevent a transition that never was going to happen without these behaviors. And they can also minimize inappropriate stimuli that can trigger agitation. We'll talk a lot about the importance of the environment a few slides from here. And they can also give people with dementia a sense of purpose and tap into their interests. And so, there's a lot of research that has showed kind of a need for purpose and meaning and activity is an enduring human need across the lifespan, regardless of whether or not somebody is cognitively healthy or living with dementia. That's a need that we all have as human beings, and non-pharmacological interventions can allow for kind of preservation of self-identity. That's a component of the research that I do. A sense of accomplishment on the part of the person living with dementia. Continuity in a role that they have. If you're able to figure out how to design something in a different way so someone can continue doing it, and just give them a goal that they can pursue, or just again, that sense of purpose. No matter who you are, whether you have dementia or don't, we all want a reason to wake up in the morning, a reason to, something that we want to accomplish or do. And non-pharmacological interventions in part are designed to do that for people. Okay, next slide, please. All right, so that begs the question, why aren't non-pharmacological interventions more widely used, and why aren't they more widely known about or talked about? Just as some of the reasons. Just that there's a lack of knowledge about them. There's not the same kind of reimbursement through Medicare or other insurance, secondary insurance, as there might be for a medication. Lack of provider training, the perception that they require too much time and effort to design or identify or present to the person living with dementia. Lack of support in a clinical environment. So if people are living in long-term care, for example, there's often just not the resources available to provide people with non-pharm interventions, namely for reasons like there's a heavy caseload for a lot of people. There's a lot of turnaround in staff, things like that. So just lacking the needed supports. And again, I already mentioned a lack of reimbursement, the difficulties with that. So next slide, please. And next slide. Thank you. And so some of the goals of non-pharmacological strategies include the prevention, management, reduction, or elimination of the frequency, the amount, and the severity of dementia behaviors, a reduction of caregiver distress, and or the prevention of adverse consequences like harm to the care partner or the person living with dementia. Next slide. All right, and just a little bit of background about non-pharmacological treatment approaches and kind of the different categories or what they involve. Just at the top, I mentioned sometimes you'll see in the literature or other places, they might be referred to as psychosocial interventions, environmental interventions, or eco-psychosocial, just so you know what that means if you ever come across those terms. And they might involve just the person living with dementia, or they might involve another target or agent, like the care partner, or the physical environment might be the target. They could also involve a combination of any of these, including the care partner and the person living with dementia. There's no agreed upon classification, but there are a lot of different interventions to choose from that are not medication based. And these include things like sensory stimulation, cognitive interventions, physical exercise. There are multi-component interventions, animal-assisted therapy even, tailored activities, and then again, interventions that help the dementia behaviors through helping the caregiver with something. So also giving them support and knowledge and resources. They can be standardized or they can be tailored. Both are highly effective. Obviously, tailored activities are best when you're able to, design and implement them. But I have worked on plenty of studies that find that any meaningful activity, any intervention is better than nothing. So both are helpful, both are better than nothing. You can target specific behaviors, or it might be non-specific, just designed to give them something to do, which will hopefully have a positive domino effect on multiple behaviors. Next slide. Okay, the first kind of category that I'll mention would be psychotherapy. And so a lot of times this is most effective in the earlier stages of dementia, although the first one, validation therapy, is used throughout the course of the disease. Validation therapy is really kind of the opposite of reality therapy. It involves kind of meeting the person living with dementia where they are. Sometimes it can be, well, a lot of times, it can be very unsettling, very scary for a person living with dementia to be having hallucinations or to think that they're in a time or place or in an environment that they're not in, and then to have someone argue with them, right? That's not going to be helpful. So this is all about really meeting them where they are instead of saying, no, 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 remember, this person passed away a long time ago. They're not here, mom. This is really kind of teaching people to have empathy, active listening, acknowledging, but you don't have to lie. You don't have to lie to them, but acknowledging their experience. That's basically what validation is. Okay, I believe you that you're experiencing this, that that must be scary, or, I'm here for you. So that's really kind of the core of validation therapy. There's a positive trend in the literature, but no statistically significant findings as far as, whether or not this has a statistically significant benefit, but certainly a lot of these techniques could not hurt. Reminiscence therapy involves discussing events and experiences from the past. It can be very therapeutic for anyone, including people living with dementia. A Cochrane review of this found inconsistent results. Some were very positive, some did not have any effect. So it's variable in the literature, like a lot of the interventions that I'll discuss, and small effect sizes. And then there's CBT, cognitive behavior therapy, which is most useful in the early stages of dementia. I use this sometimes with some of my clients who have early stage dementia, and it still works for them and is helpful for them because therapy is intended to be cumulative and building on one session to the next. And in the early stages, the mild stages, sometimes even kind of mild to moderate, this is entirely feasible. When it gets a bit more challenging for somebody to remember what we discussed from session to session, then we transition to a bit more supportive therapy. And then even after that, it becomes focused on the care partner as well, and how they really navigate this journey. But CBT has found a lot of efficacy in the literature and focuses on the relationship between events, thoughts, feelings, and behaviors. Okay, next slide, please. All right. And so environmental strategies are important to talk about because the environment plays a really big role in dementia care. I remember my first experience as a research assistant before I got my degree, my first kind of foray into aging research. And I was assisting on studies in nursing facilities and other long-term care facilities. And people who lived there would have so many more dementia behaviors, especially agitation, kind of calling out, wandering, sometimes aggression, when there was a ton of noise in their environment, when there was just really bright lights, just when there was a lot of stimulation. Because we talked a few slides ago about how people with dementia are often much more vulnerable to stressors and to triggers in their environment. So perhaps, pre-diagnosis, they could have been in an environment with lots of kind of cacophony and noise and thought nothing of it. But their ability to kind of tune that out or cope with that often changes quite a bit and is diminished when they have a dementia process going on. And so that being said, also home environments too, not just long-term care, but home environments often were not designed with aging in mind, much less the idea that somebody could deal with a cognitive impairment later on. So it's important to sort of to the best of your ability, create a dementia-friendly environment that does things like minimizing fall risk, supporting daily functioning, and reducing behavioral symptoms such as hoarding. So avoiding a lot of the clutter, things like that. And there's also research to show that whether someone does or does not have cognitive impairment, clutter can negatively affect mood, regardless of your cognitive status. And so a kind of a simplified home is better in this situation. So next slide, please. Okay, so some environmental needs that people living with dementia have include feeling comfort and empowerment, attachment and belonging, inclusion, occupation and meaningful activity, and then behavioral triggers related to the environment are some of the things I just discussed. Too much stimulation, but also too little stimulation. Boredom is one of those unmet needs that can really lead to a lot of different dementia behaviors. Poor lighting can be, whether it's too much or too dim, can adversely affect people with dementia. Difficulty finding their way. So a lot of times a dementia-friendly environment could include lots of cues in the environment, whether that would be arrows on the ground, kind of lights lighting a pathway towards the bathroom or to kind of important rooms that the person needs to be able to get to. And then we mentioned clutter, the issue of clutter. Also the temperature, whether it's too hot or too cold, making sure to assess that to the best of your ability in case there's some decline in communication where the person is not able to express that to you. Okay, next slide. All right, so simplifying the environment is so important. And research shows that reducing visual clutter can actually help people with memory problems perform better on their daily tasks. So you want to make sure to declutter. You want to minimize kind of extraneous noise. Maybe don't have the TV blaring on in the background all the time, things like that. Ensure proper lighting in the proper places. So we know that people with dementia have a lot of difficulty with their circadian rhythms. And so you want to make sure that when they're sleeping, that kind of the lighting is appropriate, but that there are enough cues, enough lights and enough cues to help them get to where they need to go if they wake up in the middle of the night or things like that. But it's helpful to avoid just kind of having all the lights on when it's time for them to go to bed because there's such a disruption in their circadian rhythms. Using cues again is helpful and safeguarding the environment, making sure that stairways and passageways are free of objects, making sure that things in the kitchen like knives and scissors are appropriately stored and put away. Cleaning agents in the bathroom and the kitchen, make sure that those are safely stored. Anything that could be potentially hazardous if the person living with dementia kind of forgets what a certain object's purpose is. Okay, next slide. Okay, so this is another category of interventions. We talked about psychotherapies, we talked about environmental approaches to dementia behaviors, and then there are sensory strategies that have been studied with variable effects in the literature, to be honest. But dementia does change the way that people see, hear, taste, feel, and smell. The environment is often perceived, like we've said over and over, as much more stressful. And sensory stimulation is defined as any technique used to stimulate the senses with the goal of increasing alertness and reducing dementia behaviors and enhancing quality of life. So these could target just one of their senses or numerous senses at a time. And then some examples are below, like music, multisensory strategies and stimulation. Aromatherapy has been heavily studied, bright light therapy has been heavily studied, and touch therapies. And I'll kind of summarize their effectiveness on the next slide. So next slide, please. Okay, so out of all of these, far and away, Music therapy has been found to significantly reduce the frequency of behavioral symptoms. And there's such a connection with with the brain and music that is really enduring. I remember, again, back to when I was a research assistant, this was such an impactful experience for me and set me off on the path that I took professionally. There was one resident of a nursing facility who was nonverbal, had dementia, was nonverbal, and would just kind of make utterances, but not say anything, and would do a lot of wandering, a lot of shadowing behaviors, a lot of getting up and sitting down, things like that. So they had multiple dementia behaviors going on that were very challenging for the nursing staff. And this particular woman, she did not speak, she didn't initiate conversation, but if you put on the Beatles music, she would sit down and she would sing every word to every song perfectly. And so that was they identified something that she loved that was very calming to her. And it gave them also a little bit of time off. So again, time to go take care of other residents, to just take a moment for themselves. And it was good for her because it was reconnecting her to something that she really loved. So music therapy has been very effective for behaviors. There's not compelling evidence to support multisensory stimulation. I suspect that could be because it might be a little bit overwhelming when numerous senses are targeted at once. There have been some promising findings, but the jury is a bit out. Again, the jury is out with aromatherapy. There have been some very negative studies and then some that trended positively. Bright light therapy has not proven effective in treating behavioral symptoms and might actually increase agitation. And the same goes for touch therapy. So that's kind of a summary sheet of the most common sensory interventions for dementia behaviors. Next slide, please. So again, as I mentioned before, sometimes you can target a behavior through something else or someone else. And so care partner interventions are often used. Again, caregiver distress is associated with worsening behavioral symptoms in the person living with dementia. They can often sense that distress, whether it's verbals or nonverbal cues. It could kind of overtly decrease the quality of the relationship between the care partner and the person living with dementia. So we really want to make sure that care partners have support as well. And there's a bidirectional relationship between caregiver burden and behavioral symptoms. So some of the types of interventions include education. And these are interventions that give knowledge or information to caregivers about dementia. This could include just knowledge. Oftentimes I will have clients who are care partners who don't understand that it's the dementia talking sometimes. And so certain behaviors and comments and things like that are not deliberate. They're a function or a byproduct of the disease process. And so sometimes even that level of education is needed and is helpful for caregivers. And so skills training is also important. So helping them develop the skills to deal with challenges in caregiving, maybe unrelated to behaviors, because as you see above, there's a bidirectional relationship. So if the caregiver is feeling really distressed, whether or not it's related to behaviors, it can increase behaviors in the person living with dementia. So just making sure they have support on a lot of levels, not just, the behaviors, but other things that could ultimately lead to behaviors. Then there are support interventions, which provide social support or enhance social engagement. Sometimes that could include psychotherapy or group therapy. The Alzheimer's Association has caregiver support groups that meet. They also have, some of them are even specific to the stage of dementia that the care recipient is in. So they have early stage caregiver support groups that are really nicely done and ongoing. There might also be case management, so interventions that involve a case manager who provides advocacy, support, information about caregiving services, financial and legal advice even, and then multi-component interventions that combine some of these, like education plus skills training, or things like that. Next slide, please. Okay, I'm just keeping an eye on the clock, so I want to make sure that I move as quickly as you need me to. And so activity interventions are my primary area of research. And so these include cognitive interventions, physical exercise, animal-assisted therapy, non-tailored meaningful activity, and tailored activities. And so cognitive interventions include things like cognitive stimulation, cognitive training. There are computer programs that people sometimes do that are, designed to provide cognitive training, and cognitive rehabilitation. The evidence is inconclusive as far as cog rehab and cognitive training. The research shows that cognitive stimulation doesn't necessarily impact dementia behaviors significantly. Physical exercise, however, is one that consistently, similar to music, is one that consistently has been associated with positive effects on dementia behaviors. And then animal-assisted therapy is traditionally used to promote social interactions for people with dementia through interaction with a trained animal that's facilitated by a human handler. And there have been there's variable findings, nothing negative, but there have been some studies that have been insignificant and then some that have had positive significance. And I have worked on one of those studies, and it was a really delightful experience. There's also non-tailored meaningful activity. So giving them something to do, such as, a task that you need help with, or asking them if they have severe dementia. You could ask them to, one of the things we did was ask them to fold towels, or, sort something for us. So it's not tailored, it's not associated with what their job used to be, or, their interests or anything like that, but it's giving them something to do that has a goal at the end. And so that's often very effective for these behaviors. And then there are tailored activities, which is really at the heart of most of my research. And there's a lot of evidence that shows that activities that are tailored to a person's preferences and abilities are beneficial and result in reduced behavioral symptoms. Next slide. Okay, so I'll spend just one more moment to focus on this, because this has the greatest benefits if you are able to take the time to do this with someone. And so tailored activities are person-specific, where you match their interests, their abilities, and their environment. Their interests could be related to what they used to do for a living, their vocation. It could be related to, something spiritual, their involvement in church and religion, or some sort of other denomination or faith. And they increase the likelihood of successful engagement, meaning that a person's not going to reject the stimulus you give them. If it's tailored, it's much more likely that they will accept it and they will do it, or become involved or engrossed in it. They could fill a void. So if one of their unmet needs is socialization, a tailored activity could involve finding an opportunity for them to socialize, whether it's a friend stopping by once a week, an old friend to sit down and chat with them, or taking them to a senior center or adult daycare, where they're able to interact with other people. Tailored activities can also help maintain roles and enable positive expressions in people living with dementia, and are associated with reductions in frequency and severity of neuropsychiatric or behavioral symptoms. Also, a very important feature of this is that studies that I have worked on and other studies, this tailored activity program kind of founder, Laura Gitlin, was one of my initial mentors in research. So I've worked a lot with her. They found that caregivers have less time on duty when somebody is given a tailored activity and they're able to get involved in it, so that that care partner can go do something around the house that they need to do. They can sit and read a book. They can lie down for a minute. They don't have to be present and on duty for quite as long. So these are known to save a lot of time and hours for care partners. Okay, so next slide, please. Okay, and so just again, when you're designing activities, if you're able to, keep in mind the needs of the person. So are there unmet needs that are present? You know, again, are they really bored? Are they very lonely? Think about any underlying unmet needs. Think about their abilities. Do they have physical limitations, mobility limitations that you need to take into account? What were their previous interests, before the onset of dementia? Because again, some of my research is in self-identity, and there is a persistence of self-identity across the dementia progression. It's just much more difficult to tap into, and for the person living with dementia to express. But keep in mind their previous interests, because that could enable them to tap into it and really become engaged in an activity. What time of day is best for them? Are they really alert in the morning? That's more typical for people with dementia. Just think about what's the right environment set up. Where should they do this activity? And then also think about how you might simplify the activity as dementia progresses, because you do not have to, dementia, and even severe dementia does not preclude doing things and doing enjoyable things and finding meaning in those. And so to the best that you can, try to brainstorm and figure out ways for them to continue doing something just in a different way. I'll give you an example. So we had one study participant who was actually an astronomer. And so initially, when he had early stage dementia, he would still read a lot of astronomy books and literature, and that gave him a lot of pleasure. He really enjoyed that. As his dementia progressed and he was not able to kind of process the long texts that he used to read and all of that, he eventually kind of progressed to looking at pictures of the planets, of the constellations. So it's still associated with that interest that he maintains, but it's in a format that's appropriate for where he is in terms of his disease stage. And so that's what I mean by simplifying the activity as dementia progresses. You don't have to give it up entirely. Okay, next slide. All right, so some conclusions. These approaches are not one size fits all. They're very individualized. There is trial and error. There could be some stimuli or activities that a person rejects and then others that they accept. Just make sure that you design them to, strategies are designed to simplify the environment, kind of the stimulation of a person with dementia, to establish routine for them or give them predictability, or to provide purpose, meaning, and engagement in their environment, engagement with other people around them, and other aspects. And then remember, there is always a way to improve the well-being and their well-being and enable persons living with dementia to be comfortable, to find meaning and purpose, regardless of their cognitive status. I firmly believe that. I've observed that in research and in clinical settings. And so always keep that in mind. Okay, so next slide. And that's all. So we're good on time. Great. That's all for the presentation. And I'm happy to just chat with you all for a little bit if you'd like.
Thank you, Dr. Regier. So at this time, I would like to invite our audience to submit your questions. If you could please use the Q&A box, and I will read those questions to Dr. Regier. We do have a few questions that came in, so let's start. Okay, so what is the why behind it potentially tripling by 2050? I'm assuming that's why is dementia tripling by 2050?
Because our population is aging rapidly. Because our older population is increasing so much. And while there are a lot of different risk factors for dementia, age is the greatest risk factor.
This research is great, but it's from 20 years ago. Is there anything more recent?
Yeah, so this research is what I'm doing now. This is what I'm engaged in now. So the citations, some of them could be older because they stand the test of time, but a lot of them are from the past 5 to 10 years. And this is also what I'm currently doing now. So my primary area of research today in 2022 is, and since 2017, is tailored activities for people with dementia, and also persistence of self-identity and caregiver support.
Great. Can you please provide the contact information for the caregiver support groups and how to find case management?
Mm-hmm. Yes. So I won't type it in right now, but yes, I can pass that on to Allegra and the other people facilitating today's presentation. And hopefully that will be helpful. Yes, I really, I've heard really wonderful things about their caregiver support groups. And I've also sat in on some of them as well. And they're really wonderful. So sure, I'll give that to her.
Absolutely. And always feel free to reach out to the Area Agency on Aging so we can connect you with case management or other support groups in the community as well. My husband has MCI. You talked about physical activity as being helpful for MCI as well as physical decline. My husband will not do anything like just a simple walk, even though all his specialists have told him it's needed. How can I get him to help himself?
Yeah, so that's very difficult because a lot of times when people have dementia, and also if there is a comorbid depression along with the dementia diagnosis, oftentimes that does happen. It's very difficult to deal with the receipt of that diagnosis, or MCI as well. But taking initiative is very difficult, both for people who have a depression and people who have MCI or dementia. Initiating things is really challenging. So I empathize with you. That is very difficult. I don't know if you can kind of have a conversation about how, I understand that this is not something that you feel like doing, that you'd rather not, but I can tell you that the research shows that even though that's the last thing you feel like doing when you're depressed, or if you have, MCI or dementia, that is what's going to make you feel better. It's that catch-22. We call it behavioral activation, getting somebody active and doing things. That's the catch-22, is that's not what you want to do, but that's the most helpful thing that you could do. And the mood improvement will follow, and the physical improvement will follow. And so if you can have a conversation, just, validating how they feel and empathizing with them, but just letting them know that if they're able to just get started, that these improvements will follow, and then it won't be so undesirable because initiative gets easier.
Thank you. And I just wanted to remind the participants, if your hand is raised, if you could please type your question into the Q&A box. Just due to time, we can't have folks come on and speak. At what age does dementia kick in?
So that is so variable. It really depends. So we do have variations of things like Alzheimer's disease. So there's early onset Alzheimer's disease, and then there's just kind of the typical onset, which is, late 60s, around then early 70s, or even later. Early onset would be something like, before 60 usually. But oftentimes with an early onset dementia, that's strongly associated with having a family history of dementia. Not always, not always, but yes. So there's that association there. There are other dementias that you usually do not see earlier, like frontotemporal dementia. And so it just depends. It's completely variable. There, like I said, age is the biggest risk factor, but there are other risk factors like vascular ones. So not taking care of your blood pressure, your cholesterol, if you're smoking, all of those things, if obesity, all of these things are associated with increased vascular risk. So it's very variable.
Mm. What specific strategies can we use to deal with, I might have a hard time pronouncing this, logopenic Alzheimer's patients with primary progressive aphasia?
Mm. Yeah, that's a challenge. I actually have a patient right now with primary progressive aphasia. As far as specific strategies, a lot of times with that, you see kind of really low mood as well. One of the things I target first with that population would be the mood, because being able to get them involved in other, in activities, in meaningful activities, a lot of that has to do with targeting the mood first. But in terms of kind of the aphasia and how that affects their communication and how that affects the family, one of the really helpful things is when they do happen to have a network around them that knows them very well, family members, spouses, that knows their interests, and kind of being able to design activities for them that are based around that, kind of knowing them and who they are, is the best way. Not everybody has that support system, and then it becomes more difficult. But if you have a spouse, if this is a spouse, the question disappeared. But if this is a spouse or a family member, and this is somebody that designing activities that aren't necessarily where the aphasia, and this is not a barrier, is kind of the way to go, and making sure that their mood is really addressed.
Thank you. Why is human touch therapy less effective than animal therapy?
Mm-hmm. Yeah, that's a really good question. Yeah, that's a good question. So a bit of this is just going to have to be speculation based on feedback from study participants. And if you read the literature, a lot of the kind of interpretations in the discussion section is in part kind of educated guesses, an interpretation of what happened. That could partially be because that is something that is kind of being done to them by another person who they may or may not know. Oftentimes it's somebody that they don't know. That can be a bit alarming and jarring and concerning, entering into their personal space, which can become a real issue for people living with dementia, which is one other reason why rejection of care is so common. And that's even often by a trusted person. But there's a real kind of aversion to that. So those could be factors. And then with the animal assisted therapy, that's a touch that they are making. That's something they are doing themselves to an animal, which is maybe less threatening than another human coming into their space, maybe a little bit more comforting, which is why we have service animals for so many situations. But that's something that they are doing, reaching out and touching something, rather than them being, the recipient of that. So to me, that's, possibility.
Okay. Can you give examples of tailored activities for people that had strong religious ties?
Mm-hmm.
Piano playing ability has declined significantly, classical, musical.
Yeah. So certainly listening to the music, if you're able to put on music for them, whether it's hymns, music from a recorded service. If you do have a recorded service for them to listen to, that could be great, whatever their faith is. Now, post-COVID, you will see, so if this individual doesn't already belong to a church or a temple or another organization, you will see so many recordings and so many live streams of different services since COVID happened, because some people are still not wanting to come into the service, but they want to hear it and they want to be a part of it. So there's actually a lot available as far as calling into those, testing out different churches or organizations. So that could certainly be a possibility. I think there's a lot you could do there as far as recordings go.
Great. Is there a way to manage spitting behavior? It is repetitive and habitual, and causes more isolation as people don't want to be spit upon.
Yeah. So what I would say, it depends on the cause of the spitting behavior. And so by that, I mean, is the cause, we mentioned some causes of behaviors. Is this just associated with the neurodegeneration that has happened? And that's just a behavior, a reflex, something that's happening with the person repetitively because certain neurons stopped firing, the connections are not there. Is that why it's happening? Or is it happening for a purpose where there's some sort of underlying unmet need that they have, and this is what they're doing to try to get attention because they can't express what that need is? So that's what I would want to explore. I would want to see, is there actually something that they need or something that they want? And giving this to them or engaging them in that, would that stop this difficult behavior? I completely understand and believe that would increase isolation and be really hard for people to manage. But I would try to figure out, is there a cause, or is it just the disease progression itself?
Can you speak to the value of small group ALF home versus large dementia units?
Yeah. The main thing that comes to mind there is staffing, and also kind of the ability to get to know the residents really well, and the ability to provide them with tailored activities, whether it's because you don't know them or because you just don't have the time and resources to do that. So my instinct is that, really smaller facilities might be better. It depends on the place, but yes, I think as far as, assisted living goes, because I think the choices were between assisted living, ALFs, and memory care. If
or a larger unit, like a small group home versus
okay, got it. Okay, yes. So I don't know. I don't know if the group home would be, what specific setting that is. But I would say, just if you're looking purely at size, then I would consider kind of the smaller assisted living facility, especially if the person with dementia if they're appropriate for an assisted living facility still. So are they at an earlier stage of dementia? Do they have significant physical limitations or significant, needs that maybe aren't ALFs aren't necessarily designed for, because those are typically for people who have, needs, but not necessarily kind of severe cognitive needs. Once those occur, then people usually transition out. But I would say that if they're still appropriate, that smaller ALF setting would probably be ideal.
And Natalie, I just want to mention, it is 12:57. We're getting close to that 1:00 mark. Would it be okay with you if we do stay longer, about an extra 5 minutes? We have quite a few more questions. We're not going to be able to get to everyone, but we'll try our best. And so folks, I'm just going to let you know we are staying longer. If you do have to leave, that's fine. We will take your questions and try to get those back to you as well. So my mother's memory care facility seems to think that an afternoon snack and watching Hallmark movies is appropriate on a daily basis. What can we do to encourage staff to engage in more creative and meaningful activities?
Mhm. Yeah, that is a hard one, because even when I, did a lot of research in long-term care and saw fantastic benefits with their patient population, and then presented them with those benefits, when we came to follow up a long time later, 6 months or so later, they weren't implementing what we had discussed. And so it's hard. A lot of times places either have, this is kind of the structure and the way we do things, and this is, how we've decided it's best to operate here. So there's sometimes that kind of point of view that's a little bit more rigid. But then there's sometimes is actually just an educational bit of it that's missing, where if you do come to them and you say, I was just at a presentation about this, or, I've been taking a look at the literature and found out, how helpful it is for people living with dementia to have, a variety of meaningful activities in their life. Is this something, you feel like is feasible here? Is this a possibility? Just wanted to bring this to your attention because I learned a lot about this recently, kind of in a non-combative way, because there is very much at certain places that I've worked with that, this is our way of doing it. We know what to do, but some places, flex a bit more. But I think coming at them with, the literature, with this is what the research says, in a non-combative way might be effective. So you could try that.
Mhm.
Mhm.
And I believe that the next question could benefit from what you just said. If there's resources for AL facilities to figure out meaningful activities, is there a good model?
Mm. There, you know what? There aren't good enough models, unfortunately. One of the other issues that people in this area of research are having is that there is an incredibly long pipeline from intervention development and, finding out that it works really well and doing your analyses and presenting it to people actually having some uptake. It's like a 17-year pipeline. Is what the research has found. And so that's right now, we're primarily, just trying to get the research out there to present and to, disseminate it to places. There are a few good books. You could check out some books by Laura Gitlin, who was one of my mentors. Her name's on the slides, which I know you guys will have access to, but Gitlin. She does have some books on meaningful activity. So I can also send Allegra, a list of a few different resources, but there isn't one that I could tell you, this is the best. Like, we have this whole database that, they just need to know about, and then it'll be great, because that doesn't really exist yet. But I can let Allegra know.
Perfect. Can you provide adult daycare facilities in Fairfax County?
Hmm.
If this is asking about what the adult daycare facilities are, we can also email that to you separately.
Mhm.
With that question.
Yes, I'm sure that there are some, but
Hmm.
I'm not sure of the specific ones. That's not my usual region where I work. So
So we can do that here at the Area Agency on Aging.
Mhm.
Another question is, my mom is starting to show signs of Parkinson's disease dementia. She is in a nursing home due to her inability to walk and her desire to socialize. How important is it for me to encourage her to go to activities at this point?
So if I'm reading right, she's there in part because she wants to be surrounded by the people who live there. So she has a desire to socialize. So is it that she wants to socialize, and that's one of the reasons she's there, but she hasn't been going to the activities? I just hope I'm reading it right.
Yeah, that's what I read. In a
Okay.
nursing home due to not walking and her desire to socialize.
Mhm.
How important is it for me to encourage her to go to activities at this
Mhm.
point?
Okay. So perhaps the issue is, does she need to do these? She's just showing signs, but there's no diagnosis. If there is, it's very early. So are these activities still important for her at that stage?
Mhm.
Maybe that's the real question here. And so yeah, I would say that kind of getting her, if she plans to stay where she is, to live there in particular, I would say getting her involved in activities there so people know her, so she has kind of a network there. They know her likes, her interests. She's developed a circle of friends. All of those things are going to really be key if she does have, dementia due to Parkinson's and it, continues to progress. Those are going to be really important for her to kind of have in place already. And so I would say, yes, it certainly couldn't hurt. But, it's not, I wouldn't kind of prescribe it necessarily at the earlier stage. But I think that the more people who know who you are pre-disease, when it's more difficult for you to communicate who you are and communicate your self-identity and your interests, the more people who know you before that stage, comes to pass, the better. So yes, if she can get involved and, have a network that knows her, that would be great, I think.
Okay. And I'm going to have to take our last question. We are at 1:04, and then we are going to wrap up together, folks. Could you give us some examples of tailored activities for someone who only likes to do research on law and economics and doesn't like pets or hobbies? He's introverted.
Hmm.
When he can't read text anymore, what might he do?
Mhm. Yeah, so I'm thinking about kind of later stages. Some things that he could do would be to watch movies or shows that are, and this isn't the only thing I would, advise, but that are, based on law, based on a case. There are podcasts about legal cases. There are, shows that are, there's Law and Order, but I don't know how much he would enjoy that. But there are lots of shows, podcasts, movies that are centered around a legal case, or kind of, a lawyer as a profession. And so you could certainly kind of weave those in at a later stage. But my guess is that if he was very interested in economics and law and got that degree, perhaps, I can't remember from the question, but maybe got that degree, there's probably a high level of cognitive reserve. So he may be able to continue in that activity for longer than you expect. But I would say just any other stimuli that are based in law, or you said economics, based in law or economics, there are plenty of, news segments that are based on that. Again, shows, movies, podcasts. So I think there's still some stimuli that you could, look into.
Great. So we're getting ready to wrap up. And as you sign out, there will be that brief survey. If you could please take a moment to answer those questions and help us provide topics that you are interested in. And I want to thank you again, Dr. Regier, for sharing your knowledge and your expertise today. It was a great presentation. And thank you to everyone in our audience for being here. We will be having a caregiver panel this Friday, November 18th, from 2 to 3 p.m. on veteran family caregivers, exploring unique challenges and resources. We hope you can join us then. And I wish everyone a great afternoon. Take care.
Bye now.
Thank you.